Sorry, everyone. So what we have now is the person's experience of ability or disability. So disability is really a spectrum that starts from complete ability all the way to complete disability. There's not a definition in the middle where someone is, able or disabled. So these three factors are always combining to influence and have the result of a person's experience of ability or disability. And I think none of us, and I'm sorry if I'm talking for you, but we all of us will have had times where we've experienced disability. So the lovely Beth here took a tumble when she was walking last year, was it?
Last year, 6 months ago.
And gave herself a very nasty fracture of one of her wrists and was quite disabled. So in that situation, her person factors have changed. So she's experiencing increased physical challenges, possibly a little bit of increased personal challenge because it was a bit stressful and painful and really, wore down some of your personal resources. The environment had changed. So because one of her arms wasn't working, she had a lot of physical barriers in her environment to just doing her normal activities. And then all of the activities that she was trying to do had also changed because she wasn't able to do them in the same way. And so essentially what's happened is those things have combined to increase her experience of disability. Does anyone have any questions about that at the moment? Don't be shy. I love questions. No?
No.
Yes?
Can I add something to what Erica was just alluding to with my little tumble earlier last year? I think obviously it was a very temporary disability that I had, but I was admitted to hospital for surgery. And I have to say I had a very pleasant experience in hospital. And it was just the little things like somebody opening a packet of biscuits for me, because I couldn't do that with one hand. And I didn't have to ask them to do it. They had the forethought to think about doing that for me. And this beautiful nurse actually used to work in elderly care, which I think somehow contributed to her ability to foresee what I was unable to do at that particular point in time. So it's something as simple as that can really make your experience a lot less stressful.
Yeah, absolutely. All right. Okay. So some really important things to remember that if you can keep these in mind, you will be supported in empowering people with disabilities. So, and this took me a little bit of time to understand, so bear with me. And I understand if it takes you a bit of time, because it is kind of a shift in how we perceive disability and how we describe it. So a person's physical, cognitive, or psychiatric factors are not their disability, okay? So their pathology or their impairment is not their disability. They are simply their diagnosis, it's their condition, it's just their physical, cognitive, or psychiatric factors. The thing is that the disability occurs in the interaction between personal factors, the environment, and what they're trying to do. Okay, so if we go back here, so the disability occurs here in the middle. It's not here. The disability is not here with the person. It's here where those three things overlap. Okay, and that's really key, and I hope you'll find it helpful when you're moving forward and interacting with people with disabilities. So disability is an experience, and its severity fluctuates constantly according to the interaction between those factors. So And when we think about the language that we use, and you know, sometimes it depends where you are. There'll be different language used in different places. But something that I think is, you know, and I don't necessarily manage it all the time myself, but is we're talking about people who are experiencing disability, not people with disability or disabled people. Okay, so we always want to put people first. So we're using people first language. So we're saying people with disabilities or people experiencing disability. We're not saying disabled people, okay, because they're a person first before they're anything else. But in terms of trying to really shift our understanding about disability, it's really helpful to remember that disability is an experience. It's not a person, and it's not a feature of a person. So that's just something in terms of shifting our mindset slightly, because when we start to think about it as an experience, we can recognize where we have a bit more control and a bit more influence on how that person is experiencing it. And that means then that if we can make modifications to the environment or to the activity, and sometimes we can modify personal factors, we can increase or decrease the person's experience of disability. Okay, so by building a ramp, for example, we can modify the environment to decrease the person's experience of disability. By changing the activity so that it doesn't go for 4 hours, but is broken up into 4 one-hour blocks, that might mean that the person's able to participate successfully. So we're changing the activity to decrease the experience of disability. A really simple example of changing person factors would be using a prosthetic for someone that's had an amputation. We're changing that person factor in terms of their lower limb amputation, and suddenly we've decreased their experience of mobility impairment. So as healthcare professionals, we have a really critical role in how a person experiences disability. And it's really important that we try and focus on enabling them and decreasing that experience of disability rather than contributing to that experience. Okay. So this is where I'm going to need a little crowd participation. And if you don't volunteer, I will pick on you. I am not ashamed of that. So if we're thinking about environmental modifications, what can we do to modify hospital environments to empower people with disability? Has anyone got any ideas? I'm picking someone as we speak. Anyone? What about Kirsty Lee? Can you think?
Making it accessible for everyone.
Yeah.
Accessibility.
So what kinds of things could we do to increase the accessibility for people?
Well, at the moment, our hospital setting is not accessible and not friendly for people who are with physical disability. So I was thinking, like, if we can have an environment that is more friendlier to people with disability who can access every programs or every areas within the hospital, that would be one way of modifying. That's what I think.
Yeah, absolutely. Yeah, and Cherish has popped into the chat signs or rails or ramps, which are absolutely spot on. And you know, when you improve the physical accessibility of a hospital, you're removing some of the most immediate barriers for people to access healthcare. And it's really important that we do that, because it reduces the need. From a basic level, it reduces the need for assistance for those people. But it's also important that we allow people to be independently mobile as much as they can. So we don't want them to come into hospital, and because of the environment, we've increased their experience of disability. So that's some really good ways of looking at physical facilitators and barriers. Some of the other ways are things like teaching patients how to use adjustable beds. So if you have electric beds, you can give them the control and show them how to use it. You might be able to shift the bed closer to a wall, or somewhere they can use to lever or to help them with transfers. So there's lots of different things that we can do to reduce physical barriers, but also that we can use to facilitate people being independent.
Can I just add something else that Cherish has put in, which I think is absolutely fantastic? So Cherish in Nauru has said for children with sensory issues, their paediatrician actually schedules them to be seen at the end of normal outpatient times when things are quieter.
Gold star for Cherish. No, absolutely, Cherish. That's such a brilliant comment, because it's really important that when we talk about physical facilitators and barriers, it's not always just about mobility, all right? It is also, as you said, it can be sensory issues. And I have friends who have children with sensory issues, and it really impacts their lives, because they need to make sure, if they want to have an easier time, you know, they're not going to places that are really noisy and busy, and that they go at quieter times. So thank you for that, Cherish. That's really great. So then there's another aspect to environmental modifications. So what might be some of the social facilitators or barriers that we can modify to empower people with disability in hospitals? I think it might be your turn, Praneel.
Oh, you're on mute, Praneel.
It's gone missing.
MIA.
So sorry, Praneel, if I'm talking over the top of you. So these, remember, we were talking before. These are some of the things that are might be less obvious than things like mobility, barriers to mobility and movement around the facility. So social facilitators really is like, you know, do we want to have a welcoming hospital that's inclusive of people that have different needs? Or do we have a healthcare facility that's quite closed off and obstructive to people with different needs? So, for example, if we use Cherish's contribution, you know, a barrier for children with sensory impairments or sensory needs would be refusing to change the appointment schedule for them and saying to their parents, oh, you know, everyone gets the same here. They get an appointment when they get an appointment. We don't care if it's hard for them. We don't care if it's hard for you. You know, you have to come at this time and we're not going to negotiate. So that's a real, that can be a real social barrier for people seeking healthcare. The other big thing is, you know, people with particular needs being met with, you know, eye rolling or lots of sighs and looking like everything's really hard work. Like, what do you mean you can't get yourself to the toilet? You know, I'm a busy nurse. I don't have time to help you with this. That's not an inclusive approach to looking after that patient. And that's likely to discourage them from seeking healthcare. So even though sometimes we have to do things differently, and sometimes that does take more work, or it takes to doing things a little bit differently, that's part of providing equity of access to healthcare. All right, so now we're going to move on to activity modifications. And this is what I was just talking about. I really love this cartoon, although it's talking about a slightly different type of equity and equality. But when we talk about equity, we're talking about fairness. So equality refers to things all being the same. And so you can see there that you've got 3 people with totally different needs who are all being given the same thing, and it's not working for really any of them. When we talk about equity, we're talking about it being fair. So we're giving people what they need to meet them where they're at so that they can have the same access as everyone else. So if we think about activity modification, so let's get rid of the word activity. Let's think about how can we modify the delivery of healthcare to empower people with disability. This is goes a little bit deeper than the physical and social factors. Does anyone have any ideas about that? Feel free to put them in the chat if you don't want to talk or your mic's not working. All good? All right. So we'll walk through it together. So one thing we can do when we're delivering healthcare to people with disability is to never make assumptions about what they can and can't do. So everything we want to do, yes. So Pranil, I didn't even think of that myself. That's brilliant. Pranil's popped in the chat, hospital in the home, deliver the service to the door. And that's a really great suggestion. So that, really is exactly what I was just talking about in terms of meeting people where they're at and providing them with the opportunity to access healthcare in a way that means they can get what they need. So thanks, Pranil, that's brilliant. So independence is about checking with the person, in a respectful way. Hi, I can see that we might need to do things a bit differently with you. Can you tell me how I can best help you to make sure that we're meeting your needs? Sometimes, as healthcare professionals, we're very busy and we have a tendency to try and be very efficient. And sometimes that means we will sweep in and take over for a person without checking whether or not they want us to do that and without checking whether or not they actually can do what it is that they need to do. So that might be mobility, that might be transfers, it might be feeding, it might be showering. So these are things that we need to be really mindful that we don't want to take more independence off a person with different abilities. We always want to be allowing them to maintain what independence they have. And this really feeds into the idea of control. It's really important that we as much as possible, we ensure that someone who's experiencing a disability can have control over their bodies, control over what they're doing, and control over their healthcare. And that's something that I think goes across all patients that are in hospital, because to some extent, every patient that's presenting for healthcare has to give over some aspect of control. And for some of us, that can be really hard. And that's certainly something that I think I would have a lot of difficulty with if I was in hospital. And again, that supporting someone having a sense of control can be as simple as asking them what it is that they need and listening to their answer. That can be also a bit challenging for us, but sometimes, we just have to, if we're going to ask a question, we often have to accept what the response is. The other thing is things like giving them the controls for their bed, if you have electric beds, giving them a means of calling for assistance. The opposite, I think, when you take someone's control away, you increase their feeling of vulnerability. And that can be really, really traumatic for people, for anyone, but especially for people with disabilities. If you're lying in bed, if you're normally in a wheelchair that you can operate yourself, and for some reason you have to get into bed and someone puts your wheelchair outside your room and you have no means of calling for assistance, that's going to be a real experience of loss of control and possibly very traumatizing and a real experience of vulnerability. So it's really important that we're thinking about what are the things that are important for this person, and am I making sure that they have them? Dignity and privacy. So very important that we try and maintain someone's dignity and privacy. And for people with disabilities, that can mean sometimes we have to do things differently. So if we need to do examinations, if we need to ask questions, all of those different things, we need to be thinking about how are we maintaining this person's dignity and their privacy. Just because someone might not be able to communicate, you know, via speech, or we don't think they have the cognitive ability to respond, doesn't mean that we can speak about them to other people. They still have a right to privacy and they still have a right to their dignity. Respect and informed consent. So again, we're always making sure that people understand what it is that is happening with their healthcare. So that might mean that you need to engage family and caregivers to communicate in their ways. So maybe they use sign language, maybe they have different ways of helping that person understand. So it's really important that we are always trying and giving the person the opportunity to understand what is happening. We don't talk about the patient in front of them. We don't talk over the top of them. And if we see other people doing that, like doctors, sometimes they're not very good at this, we remind them that actually it's really important that that person is respected. You know, it's a bit like in ICU, you would know this. We never know exactly when critically ill patients can hear us and when they can't. And so you always need to be mindful that you're talking to them, you're explaining what's happening, what's going on, what you're about to do. And the same thing goes for people with disabilities. You never assume what they can understand, what they can hear, what they can't. It's always better to be safe than sorry. I won't go over the equity again because I think we've covered it, but that's also really important. We need to be mindful that we're ensuring equity of access to healthcare. So person factor modifications. This can be a little bit, I think it's really important that we remember that it's not the person's responsibility to compensate for environmental and activity factors. Okay, so there are sometimes, like I said, with particularly with assistive devices, where we can modify or compensate for a person's physical status. And Cherish mentioned beautifully that we can also, you know, support through changes to the environment. We can support someone's sensory processing, their sensitivity to sensory input. But it's not always possible, and we should be careful when we're talking about modifying person factors that we're not implying that it's the responsibility of the person to do that. Can anyone think of any ways in which we can modify, or we can support a person to modify person factors? Yes.
Can I ask a question, Erica? With person factor modifications, does that mean maybe having the primary caregiver available for support?
Yes.
If that's what they would like?
Yeah. Exactly. So engaging the things around them, again, you're using your environment, but engaging those people that know them well.
Yeah.
And that can also support them to communicate, to do the things that they need to do.
Yeah.
Yeah.
Cool. Thank you.
Yeah. So we're not necessarily saying, you know, we need that person who's had an amputation to grow back their limb. It's about those things that we can do that help the person function better.
Oh.
Yeah. So Pranil's said, I think awareness and talks such as this will modify most of the healthcare workers' approach towards people with disability and hence person factor modification. Yeah. And I think maybe you're also hinting at something there, Pranil, which is really important around we bring person factors as well as healthcare professionals, and we need to modify our own person factors sometimes as well. So some of the things that we've got on here, we're looking at ways that we can facilitate mobility. So that is more for the person. So that might be things like wheelchairs. So rather than the big physical access stuff, but it's things like their, you know, wheelchairs, walking frames, that kind of thing. Can we do, how are we going to facilitate their communication? So if, like Beth said, if someone comes in who has a primary caregiver and you're having trouble communicating with that person, they might be able to tell you, oh, this person only communicates through a communication board, or they like to write things down, or they prefer it when you write things down. So facilitating that to compensate for a communication problem is really important. We can use reorientation strategies, and there's lots of different ways that we can support self-care. One really important thing that I want to emphasize with this, particularly because I think a lot of you are nurses, is that it's a very, very common experience for people with disability to not be given adequate analgesia. So sometimes that's because they're not able to express their pain score or their experience of pain adequately. But also sometimes there's some kind of stigma around it, and there can be some, you know, automatic assumptions made by healthcare professionals that people are not experiencing pain or as much pain as they actually are. So if you've got a patient that you think has a reasonable reason to be experiencing pain, and you're having trouble either with, like, their behavior is disturbed or they look distressed, please don't be shy with pain relief. Speak to the doctors and advocate for that person to try some, you know, titrated, but some pain relief to make sure that we're not, you know, putting that person in a really uncomfortable position with no way of relieving it. The other thing is that some people with disabilities, you know, their disability is lessened because they take particular medications. So it's really important when they present to hospital that we try to get as much information as we can about what their regular medications are so that we can continue that. And that can be, you know, that can be regular pain medication. It may be medication that manages muscle spasms. It may be medication that assists with conditions like ADHD. So it's things that are really critical to their experience of disability, and it's really important that we get on top of that so that they're not put in a situation where they're suddenly without that support. The other thing, and I am definitely biased here, but if we're going to talk about person factor modification, getting rehabilitation and physiotherapy involved can be absolutely critical. So what if we don't know how to help? What do we do? Someone has to answer this question. I won't move on until someone answers it. So what if we're looking at a person and we're thinking, oh goodness, I don't want to do the wrong thing. I'm really worried. I don't know where to start. What do we do?
Cherish has said, ask them how we can help.
Cherish, another gold star. So the best source of information about how to empower a person with disability is the person experiencing the disability, okay? They are the absolute experts of their own experience. And sometimes they won't necessarily be able to communicate in a way that we can understand, or they might be so unwell that they're temporarily unable to. And in that case, we look to their family and caregivers. Asking the person with disability or their family and caregivers how you can help is one of the most powerful ways for them to feel respected and heard. But the caveat on that is don't ask them and then ignore what they say, okay? If, for example, if they ask for something that you're not able to provide, just discuss why you can't provide it. Don't just pretend like you never had that conversation, because that's almost worse than not asking in the first place. But they are the absolute expert of their experience, and they will probably be able to give you hints and tips and things that they've learned over the years that make everything work better and will help you do your job. All right, we're doing well for time. We're going to do a quick case scenario. So we'll go through it and then I'll get you guys to give me some ideas about what to do. So we have Tom, who's a 24-year-old man who has an intellectual disability. He lives with his family. He does not speak, but he does communicate with his family using their own sign language that they've developed. He is independently mobile. Tom had 4 teeth removed 1 week ago, and since his surgery, he's been refusing to eat or drink. Today, Tom fainted at home and his family have brought him to your hospital's ED. When you meet Tom, he doesn't make eye contact with you. He looks distressed and uncomfortable, and sometimes he shouts. So what will you do to make sure you deliver effective healthcare for Tom and make his experience as positive as possible for him? Either in the chat or feel free to talk. So you can think about the factors that we spoke about before, if you want to break it down into those areas.
I suppose, Erica, this kind of scenario can actually happen anywhere in a healthcare facility or a primary health clinic.
Not just ED. Yeah, definitely primary healthcare. Yeah. So what might be some of the environmental factors that are impacting on Tom at the moment? Yeah, we've got Marina in Nauru. Involve the family to help with communication. Absolutely. And what kinds of things would you be wanting to communicate to Tom at this point? Yeah. So Siki in Nauru says level of his pain and where. So I'm really glad you picked up on that. So I can imagine most of us might have, well, some of us have had teeth removed and we recognise that it's a really painful experience. And it's possible that Tom's been experiencing pain for this last week. And I think trying to get on top of his pain would be a really important first step, because then we might be able to do a better examination. So it may be that he's got a raging abscess in the back of his mouth, and that's why he's not eating and drinking. So you can see how managing that pain in the first instance, plus some communication, will assist, hopefully, to do a better examination and then move on to treatment. Any ideas about the way you might modify how you do that healthcare? So this is the activity factors. So what might be some of the ways that you change how you approach from if you were talking to a person that didn't appear to have any disabilities at all? It's very suspenseful.
Isn't it?
Someone going to talk? Is it going to come in the chat? Christy Lee, how might you approach Tom if you were looking after him?
I will involve his primary carers
Mhm.
for most of the care that I will provide since he's intellectually impaired.
Mhm.
And then I will also collaborate with, probably I'll get the dental people to come and have a look at him.
Yeah.
Should he needs further clinical care.
Yeah. Beautiful. Thank you. And something that's also really helpful in these kinds of situations is if you've had a good chat with the family and maybe you've managed to communicate with Tom and you've learned some really good tips and tricks about things that Tom likes, things that he doesn't like, and ways that can improve his experience of healthcare, it's really, really important that we communicate that to all of the treating team. So we might have a really cranky old man dentist and we don't want him to come in and get really angry with Tom for not talking and not responding, because that's not going to help Tom's healthcare experience. It increases his experience of disability. So instead, what we want to try and do is make sure that we catch that dentist first and we say to him, look, you know, the best way to communicate is speak with the family. They will then communicate with Tom. He's in a lot of pain at the moment, so he's not, you know, really wanting a lot of examination, but we gave him pain relief half an hour ago, so hopefully that might have improved his situation. So we're really trying to strengthen the whole team's ability to look after Tom and not let him have to repeat himself or his family have to repeat themselves. All of that just contributes to them feeling like the healthcare system isn't listening. So we want to sort of try and share that information so that their experience is better. Anything else you wanted to add for Tom?
I think we're all aware of this. Body language, I think, and creating a comfortable environment for any patient, regardless of their disposition in hospital. I think body language and communication style go a long way to relieving someone's discomfort.
Yeah. But if you can imagine, if you were someone that has different abilities and does experience disability, some people are really, they're very conscious of people's body language and how they're received. And especially if they've had bad experiences in the past, they might be looking for those, you know, they might be trying to protect themselves by anticipating that. So if we're using very open language, warm, friendly, and, you know, really putting the equity and the respect and the dignity of that person at the forefront, we're going to really have a good relationship with that person. And keeping in mind that you don't have to know everything. You don't have to be an expert, and it's okay to make mistakes. But if you've had that open communication with that person and their family, where they've recognized that you're open to learning, you're open to trying different things, it will go a long way for smoothing over those bits that are a bit bumpy. All right, we're almost finished. So this is just a cartoon that I really like because it really flips that that idea that of disabled and non-disabled. So anyone can experience a disability if the conditions are right or if they're wrong, as in the case of this cartoon. And really, what I want you to take away from this session is that we're always trying to be an enabler. So, we don't want either of these people to be on the wrong side of that grate there. We want everyone to be able to access the world as they want to. And particularly when it comes to healthcare, we need to make sure that we're supporting people to do that. That's the end of my chat. Has anyone got any questions or any discussion topics or any comments? I'd love to hear them. Or in the chat.
Whilst people are maybe typing things in the chat or thinking of something they may have to say, I would just like to say thank you, Erica.
Oh.
Certainly, from my point of view as a critical care nurse, I have certainly learned quite a number of things we can do to make that patient experience more pleasant in a hospital. And I think, honestly, the thing that sticks out for me is Cherish and her crew in Nauru. Just that simple addition of having children with sensory disabilities having their appointments at the end of the day. I think that really sums everything up for today. It doesn't have to be anything big.
Exactly. It doesn't have to be complicated. Yeah. And yeah, those things are really important. Well, thank you. It's my pleasure. I know we've gone a wee bit over time, so unless there's anything burning that people want to say or ask, we will log off.
Before we do, I know I sound like a cracked record. If you haven't already, can you please try and fill in the registration form that I just posted in the chat group, please? And also, just one other quick question. We'll run another webinar, NurseTOK webinar for March. Does anyone online at the moment have a topic of interest that they would like to hear about? It can be clinical, non-clinical. It doesn't have to do with nursing. It can be any topic of interest whatsoever.
We can hunt around for special guests if there's a topic that you would like to hear about. Thanks, Christy Lee. And thank you, Pranil.
No suggestions? If you do have a suggestion, maybe pop it in the on the Facebook page, or you're more than welcome to send me an email or a text for next time. Thank you all very much, and hopefully see you in March. See ya.
See everyone.
Thank you.
No worries. Bye.
Thank you. Bye. Goodbye.